Hi everyone, my name is Fahad Mola. I'm currently a fourth year medical student at CHSU and I am creating this video because I just matched into psychiatry earlier this March, and I'm super excited about it, and wanted to kind of give my 2 cents because I had a lot of people come up to me and talk about how do you get into psychiatry, how do you perform interviews, and a whole slew of questions, and I really wanted to create a little bit of a video series to help learn how to do psychiatric interviews and then create assessment plans based off the psychiatric interview in an MSc, and hopefully give a little bit more information on how to conduct these interviews so you can do well on your rotations and your sub-Is. Um, this is just my knowledge and what helped me, and a couple of other students that I know found it to be really helpful. So I wanted to share whatever knowledge I have so that for anyone who's going into a sub-I or a rotation and is nervous about psychiatry and wants to do well on the rotation, has an opportunity to really shine on the rotation and learn as much as you can about psychiatry, especially because I know these type of interviews are so sensitive and require different finesse than maybe your traditional interviews in different rotations like FM, IM, um, PEDS, for example. So being able to understand how to conduct these interviews and conduct them well, and build rapport with the patients, which is one of the most important things, obviously, in psychiatry, uh, is hopefully something that I can bring to the table and help get a little bit more clarity on, because it's a little different than just running through old cards or OPQRST. While still important in the interviews that we do, there's a lot more broader questions that we have to ask, depending on the setting, the acuity of the patients, and hopefully I can kind of give a general picture and example, and we can kind of work through doing, at least in this part, for example, a psychiatric interview and what we're looking for. Psychiatry is really one of those fields of medicine that is almost like the last frontier, people say. It is not, um, diagnosable with lab tests, and it really requires a good interview, good rapport building, and a real clear understanding of the DSM-5 and what are the requirements for diagnosing a patient with a specific psychiatric disorder, and then what to do with the plan for that patient based on how they're presenting on the MSc, and creating and curating a storyline for your attending, which kind of supports that. So this is just one hopefully tool that you can use on your wide onset of tools to really become a better psychiatrist. And I hope to give my 2 cents for the little I know as a fourth year medical student. But I really hope that this is useful to you. I think psychiatry is one of those fields that really touches the medicine and the treatment of someone's humanity. It touches the internal and external trauma and conflict that is very nuanced and very difficult to understand sometimes. And there's a lot we can get from these psychiatric interviews that allow us to understand, um, diagnose, and treat those internal and external conflicts, and allows us to get better touch with someone's humanity. And when you're working on that, how people interact with the world, how people interact with their peers, and how that internally reflects in their thinking, it can be a very sensitive discussion. So there's a couple things that I'm gonna, talk about straight off the bat, which are super important, is building that understanding that you're gonna be talking about sensitive subject matter, not into detail, probably in your first interview, but as physicians, we already get to hear so much information about someone's lives, and this targets another aspect of it, which you will see later, and very sensitive parts of it, which might feel invasive sometimes. So, uh, understanding why we're asking the questions we're asking, understanding the purpose is going to help us make sure that we ask these questions properly, while not getting too invasive with our questioning, which really isn't needed. But sometimes um, students get curious about things that we don't really need to get curious about to create a diagnosis, and it can kind of threaten the rapport building or the ability for the person sitting in front of us to really explain what they're feeling. So I wanted to create this first and foremost to say the most important thing is, um, one, I really am going to go through my structure on how I conduct interviews and maybe give a little bit of examples here and there, and um, overview most important requirements needed to get the full history of a patient. You won't probably need to do this every single time, especially in follow-ups, but the first time you're meeting a patient, especially as a third year, and probably the first couple of weeks of the fourth year, um, you need to be asking all these questions, and I'll explain why, and I'll explain how to ask them. And also, we need to make sure to ask them sensitively and create a therapeutic relationship and kind of have the finesse to ask these questions, but in a conversational manner, which is not, very, it doesn't sound like an interrogation. So to do that, I want to request one thing, is that I'm gonna show you my template on the questions we're about to ask, and I want you to, if you're willing and able, to fill out these questions as if you're the patient, and I'm gonna ask you these questions, and write them down on your own life, and you'll see, we've all been a patient, but not all of us has been a patient in this specific field. How difficult it might be to talk about some of these things, and how important it is to ask them with curiosity, with sensitivity, and most importantly, with the intent to come up with a game plan for this person sitting in front of us who is sharing these personal details about their lives. So that's a little bit of my 6-minute intro. I'm gonna plug a couple of things that also helped me. Maybe right now I can do it just because I have these sitting on my desk all the time. This book I think could be found on Amazon. Sorry, it's not very clear, but it's a pocket handbook for interview guide for evaluating the DSM-5 psychiatric disorders and mental examination. And it basically has all, I don't know if you guys can see it, but all the criteria, it's not very clear, sorry, but all the criteria for childhood and adult disorders, at least the most pertinent ones. There's not a single thing in this book that I couldn't find that I needed, but the criteria needed, because the DSM-5 is, our bread and butter and is a must need. And for some of those intermittent explosive disorders that you might not constantly see, or, differentiating bipolar type 1 versus type 2, or schizoaffective versus, bipolar and things like that with psychotic features, that's a great book for you. I also have this book, which is a great read, Suicide Assessment, and this is by Sean Christopher Shea. This helps kind of, especially in an inpatient setting, was a really good read of understanding how patients who are coming in with suicidal ideations or coming in with suicidal intent plan, how they might present. Really good book. It's not a bad read. I would highly recommend it, and is something that I think everyone should read if you're going to the field. And then, of course, Stahl's Essential Psychopharmacology is a big book. I am very interested in child adolescent psychiatry, so I also have this pocket DSM-5 guide for child adolescent psychiatry. And yeah, I think that's a really good quick summary of everything. Let's get to it, the more important stuff of how to conduct these interviews. Alright, so I hope I'm doing this right. Basically, you should be able to see me and my entire screen. So hopefully that helps a little bit. This is the template that I used to use when I was a third-year medical student and the beginning of a fourth-year medical student. I really liked it. This is not something I created at all. My dad, who's a psychiatrist, actually is the one that kind of had the basic rubric of this template, and then I kind of refined it as the year went on. And I now share this with other medical students, and they refine it in their own way that makes sense to them. I really like this because it created kind of a mental imagery on where things should go when I'm writing things down. So I could really look at the patient and kind of tick things off as I'm going on. I hope this is helpful for you. Like I said, I really want you to do this with me. So kind of create this template on your own. There's this big empty space usually here, which I added these things, but you don't need to add that. But med history, substance history, history of any trauma, family history, developmental and social history, academic and work history, legal history down here, and then hospitalizations at the bottom, as well as a psychiatric timeline and medications. And the most important thing, I think I said legal history, but if I didn't, legal history, danger to self, firearms, DTO, GD can also go there as well. And then some orientation questions, 07s and recall, which I really didn't use that much. But over time, I've added these small little text boxes that you're going to see here. Let me make sure I have my pointer on. So like these small little text boxes, especially in my third year, I used as I went through my rotation and realized I was forgetting things and added things, especially down here in social history. But for our purposes, I think it would be really helpful to go along and kind of fill this out yourself as I'm asking questions and really see, kind of go through this process and see how it works. Again, if this is something that doesn't work for you, please do not use it. It took me about, a couple tries to really hone this down, but once I had it down, it was probably the best template for me. So I hope it's useful to you. So let's get started. We're going to start really simple with the intake and again with the history taking. So I want us to pretend that I'm going to change this to text box here. I want us to pretend, we're at the ED or we can even be first time meeting the patient at inpatient unit, right? So usually that's going to be your two most common scenarios. Another rotation might be an outpatient clinic as well. A lot of those are going to be follow-ups that work a little differently, or an intake outpatient as well. So pretend this is just your hour-long inpatient or outpatient first intake. Let's just say we're at inpatient, they came from the ED, and they're on a hold for 5150 at the ED or now inpatient, and now we have to evaluate them for the first time. So I'm going to say this is like a 57-year-old Caucasian male coming in for suicidal ideations and self-injury behaviors. Also, just preface, we might be talking about a lot of like trigger warning type of thing, a lot of sensitive subject matter, so just be aware of that when we go into this kind of stuff. But let's just pretend this is all we really know about the patient. This is what they came in, this is what they're on the hold for, and for wherever the setting is, this is the first time we're meeting the patient. Now, traditionally, we would kind of, in other specialties, we would really just go through old cards, kind of ask them those questions, but that's not really what we do here. Different physicians do things differently. The first time I ever rotated with someone, they said, go through all this kind of stuff first. On the right-hand side, some people ask for the bottom, some people, go through this first. I would normally say, we try to make this conversational and a flow. So, you're seeing this patient first time, introduce yourself, say, hi, my name is so-and-so, I am a X-year medical student rotating under Dr. This. They'll be here shortly, but I wanted to do the intake and get to know your history better and do the best I can to help navigate you through this difficult time. Thank you so much for letting me be a part of your care. So from the get-go, a lot of patients, when they hear they're on a hold, are not going to be happy. For those of you that don't know, 5150 is an involuntary 72-hour hold due to psychiatric reasons. So that could be DTO, DTS, or gravely disabled. DTO meaning danger to others, DTS meaning danger to self, and gravely disabled meaning that they cannot do basic daily livings, for example, eating, housing, or there's a whole list of ADLs, but any of those due to a mental illness. So that's a very brief synopsis. There's also a 5250 hold, and there's more. And this is specific for California, obviously. So, you introduce yourself to the patient, their chief complaint, ask them what brings them in today. This is going to be important later for insight and understanding if they know why they're in. But that kind of comes later in the MSC portion. So, they say, I'm coming in for suicidal ideations, but I'm fine. I have these jobs and kids, a stressful job. I have these kids I need to take care of. So I really need to get out of here. Okay. Now, when someone's on a hold, or we're going to place them on a hold, whatever the situation here is, I know it's a little vague, but our job is to figure out whether they need to be on the hold, whether they need to be placed on a hold, and what treatment regimen we need to come up with. As many of you know, as you're approaching your rotations, psychiatric medications take about 4 to 6 weeks to take the highest effect, and these holds only last for 3, 14, sometimes a month, but usually 3 days to 14 days. And if they're on a 1799, it's a day. So it's going to take a while for these medications to take effect. We know that. So our job here is working backwards is, does this patient need to be on a hold? And how do we figure that out? In psychiatry, I think the biggest thing I hear is that so much of it is subjective. And that can be very hard for third and fourth year medical students. Like, how do we know what we're supposed to do with a patient? How do we know something's working? How do we know if we're supposed to place them on a hold? And that's something that I'm working on to this very day. You don't want to take away someone's rights and autonomy by placing them on a hold unnecessarily. And you want to make sure what you're doing has some clinical, objectivity. So we're going to start with, are we placing them on a hold and why? And then work our way backwards. And we're going to get that information from doing the intake and asking these specific questions. All these questions are going to later go into our biopsychosocial kind of timeline and schema to figure out if this patient meets the requirements to be placed on a hold based off their psychiatric diagnosis, based off their MSE, based off of their history taking. So this is the first and most important part. That is why doing this part is so important, because you want to build that rapport with the patients to get the best history possible. And then, to build that rapport to basically say, hey, I think you need to be here, and kind of work with the patient to do so. So let's just say, again, this patient is saying, hey, I am here because I was having some thoughts of hurting myself. They were fleeing, and I really have a stressful job that I need to go back on Monday. And I, have these kids and they need to be taken care of, X, Y, and Z. What I would naturally do from this stage is follow the patient in what they're trying to say, right? So they brought up work and kids. So I would follow the patient there. Okay. Sir, I hear that this is a stressful time for you, and I want to make this as smooth as possible. I have some questions that I need to ask you today. So tell me, you talk about your work and your kids. Tell me what you do for work. Okay. So we're already, if we scroll down, are hitting this part, academic and work. Now, this is important for a couple reasons. It gives an idea to the general understanding that this patient might have of the healthcare system, and might have a general understanding of what they know about mental health, and kind of show if any of the stressors are coming from work, which we later put into our biopsychosocial approach. So let's just say this man runs a company, and let's just say he graduated college with a BA or something like that. And he says that it's stressful, right? And you ask more questions and you find out that it's stressful, it's contributing to his stress. Okay, sounds good. And you mentioned that it sounds like this is a stressful job for you after asking more questions. Tell me, do you have a good support system at home? You told me about your kids. Tell me about that. So now this gets into, do you see how, how that flows, right? It's not like you're asking, okay, onset, what makes it better or worse, quality, those things are not going to really be helpful right now. Of course, we're going to ask, when did these symptoms start? X, Y, and Z. How long have they lasted? Things like that. The DSM-5 criteria that we talked about. But kind of flowing with the patient is going to give us the history in a way that they don't feel like they're really meeting with a professional. They're meeting with, someone who's just conversing with them. So let's just say they have 3 kids, and you said that they're a lot to take care of. Tell me more about that. Recently divorced or going through divorce. And so he is no longer with wife. Wife doesn't have time with friends, and no good relationships. Okay. Social history is super important because what we often do is ask for collateral, meaning that we'll call someone from the family that the patient is close to and get history of how they are outside of, the current situation, outside of how they were today. What does their longitudinal history look like? Because sometimes patients don't want to be upfront about the things that they've been going on with, and family members might be. So getting that collateral is important. So at this time, asking for well, do you have anyone that we can talk to? We always like to hear collateral from family members or friends that might tell us how you were doing before you came to the clinic. If he says, he has no good relationships and things like that, that also puts a red alert in my brain. If we discharge this patient, who is going to be his support system for the stressors that are going on in his life, right? So let's just say he says, I don't have anyone either, And at this time too, I have a little text box here. I can maybe zoom in and, other way. Right here, ask relationship history. So when was your last relationship? That's really helpful for some other diagnoses, but he's coming in with other things right now, so we won't really ask about that, but you can get into more detail about the divorce and what happened and things like that. But again, that's kind of the trap that some medical students fall into. How are you feeling about the relationship right now? How do you feel about the divorce? But that doesn't really help, right? Because we got the information. He's going through a stressful time. He doesn't have any close family or close-knit friends right now because of the stress of his job. He's working totally over there. And that gives us an idea of the picture of what his social support looks like. We also have developmental history. If there's any developmental delay or intellectual disability, it's good to know that information as well. Asking about domestic violence history, asking about, other things, birth control and protection, that's kind of helpful if we're, giving something like valproic acid or something like that. In reality, that's not what we're doing here, but those are questions that, again, strategically we can ask hey, what are your long-term plans if they bring it up? And who are they living with too? If he's saying living with no one and the kids are at the mom's house, then okay, he has no one to watch after him, at home. So it's just giving a clear picture. Okay, let's just say after that, we talk about developmental and social history. He says that he doesn't really have any close family. Okay, next thing we can go to. It sounds like, we can say, it seems like you don't have a lot of supportive family, but I wanted to ask more questions about your family. Do they have any psychiatric or mental health illnesses that run in the family that we should be aware of? Let's just say he says, yes, mom has depression, dad has anxiety, both took let's just say Lexapro. Okay, that's all we know. Family history is really important because when we look at the biopsychosocial, the bio part of it is, part of it is really the genetic predisposition to psychiatric illnesses. So if there's family history of any mental health illnesses, there's also a possibility that the patient presenting today, this person might also have some predisposition to mental illness. Also, what you'll learn is that medications that work for family members often work for the patient as well. So getting information about what illnesses they had and also what medications can kind of help us develop an assessment and plan on what to do later. Okay, ask about family history. We get that family history as well. Now you're kind of stuck with like, okay, we're kind of running, patients not being forthcoming with information. We can now, maybe switch back and get into our diagnoses. So from there, I'd be like, okay, so your mom and dad had depression and anxiety. Do you feel like you're experiencing any depression or anxiety right now? Patient's like, no, I'm fine. I'm like, okay, I'm glad to hear that. Let me ask you a couple more questions. This is where we would get into some of the diagnostic criteria, okay? So for example, MDD, you need to have 2 weeks of SIGI caps, right? So what are those? Sleep disturbances, decreased interest, guilt, decreased energy, decreased concentration, appetite or weight changes, psychomotor agitation, and suicidal ideations. And you need at least 2 weeks of those. Often you need decreased interest and sadness, right? So what I like about this template is what I would do is I would have the most common ones I would normally see listed out. And if I had clinical suspicion that there was something else going on, let's just say schizoaffective, then I would create a circle and write down like S.A. Okay. What I like doing is having the diagnostic criteria already written out for me. 2 reasons for that. One, as a third-year medical student, there's a lot to remember. So SIGI CAPS is an easy one, but you might have one for PTSD, heart, right? Hyperarousability, avoiding stimuli, re-experiencing events, and then distress. So all these mnemonics are good, but it might be overwhelming at first to remember them. So I would have them written down. And what would also help is while I'm kind of going through the list of SIGI CAPS for MDD, which is my primary clinical suspicion here, I would check them off. So I'm talking to the patient and I'm asking, I wanted to ask you about your sleep. How's your sleep been? Sleep's been bad. Okay, check that off. I don't have to write down sleep disturbance check. I can continue to have the conversational approach with the patient while also being able to cross things off and then later on talk to my attending, remember like, okay, these are the things that I had concerns about or that I found in my findings. So please fill out your family history, your academic and work history, and your developmental social history kind of stuff here as well. But let me continue here with, let me just make sure I have something that you can differentiate here. So I'd have all these written down. So let's just say I haven't really been sleeping. How long has that been for? Let's just say it's been for 1 month. Okay. So 1 month. I would now check that off. I'm kind of still working on SIGI CAPS, right? But I'm also going to ask questions that I know affect sleep. And then also get me questions about, questions about the patient as well. So, for example, okay, there's a lot of things that can affect sleep. Stress is one of them that you've mentioned to me, but also sometimes substances can also affect our sleep. Tell me, do you have any substance use history that I should be aware of? For example, coffee. You might be looking at me and being like, why are you talking about coffee? In reality, we know that affects sleep. We know he has a stressful job, and it is a lead-in to asking about other substances that the patient might not be forthcoming about. Okay, so let's just, he's like, yeah, I drink coffee. So we put coffee here. Okay, so we can know that maybe the sleep disturbance is because of MDD, or it might be because he's drinking coffee. Let's just see, he drinks 1 cup in the morning. Okay. Now I'd ask more questions. All right, any other substances? For example, and any other questions? Just leave it open-ended. No. Okay, for example, alcohol. He's like, okay, yeah, I drink alcohol. Alcohol every night before bed. Okay, any marijuana? No marijuana. All right. Any cocaine, methamphetamines, heroin? No, no, no. Okay, sounds good. So asking those questions with the lead in and then getting more information is kind of how we do that. Okay, that can affect our sleep as well. Tell me with how it's been affecting your sleep. How has your energy and concentration been? He's like, okay, yeah, it's been bad. I haven't been able to focus at work. My boss is getting mad at me. I come home and I don't want to do anything. So we've now checked off energy and concentration. Okay. All right. That's unfortunate to hear. Tell me, with that energy and concentration, have you also had any, associated decreased interest in activities that you normally enjoy? Or sometimes I like to ask, okay, what about any hobbies to build a rapport? And he says like, well, I like fishing. Well, have you been wanting to do that this last month? No. Okay. All right. Slowly start building that, and you start asking questions. So let's just say he says he's sad, he's had these suicidal ideations we're aware of. He feels guilty for the divorce and how it's affected on the kids. So he's already meeting criteria for MDD. Now, you might just stop there. Normally, I would also look at other things as well. We can have MDD with psychotic features. The reason we're concerned about psychotic features is if they have auditory command hallucinations, that's almost a get-go for needing inpatient psychiatric care. So, because we don't want them to be a danger to themselves or others if the hallucinations are saying to hurt themselves. Sorry, I'm checking time to make sure I'm not running over, so I'm hoping that this is helpful. Okay, so I would ask next, sometimes with depression, we might start hearing or seeing things that normal people can't hear or see. Tell me, how many people do you see in this room right now? Just you and me. Okay, sounds good. Have you heard any voices recently telling you to hurt yourself or harm yourself in any way? No. Okay, so we're not really worried about MDD. With psychosis, I'm canceling this out. Something we also see is that you can have depressive symptoms before or after mania, right? Bipolar picture. Ask questions about bipolar disorder as well. Do you feel like you have decreased sleep where you don't have to sleep for 7 days at a time and can be awake for hours? No, not really. Okay. Has anyone ever told you that you've had pressured speech where you are talking more and people are telling you to stop talking so much? No. Okay. Any grandiosity that you feel on top of the world, better than everyone else, that everyone's beneath you? No. Any excessive spending? No. Normally I would ask in, again, more conversational manner, but you kind of got the gist from what I was doing previously before that, how to ask these questions and how to make sure you're asking them in a good way that makes it conversational. That really wasn't all that, but I'm just doing that for time's sake purposes because it's been 24 minutes. So let's get back to more of the conversational interviewing. Now you can ask a little bit more questions about the patient's history. So we can go into, and notice that I'm kind of going back and forth, right, based on what the patient told me. So let's just say we ask them questions about depression, and let's just say, we do a little bit OPQRST. Sometimes I like to ask, how often do you feel this way? Let's just say they feel it 4 times a week, and they say it's a 9 out of 10 of how depressed they feel. Okay. Now what we've done is we have a history of suspicion, right? We need 2 weeks, it's giving a month, we're meeting 5 out of 4 symptoms, and now we know how depressed they are. If they said something like they're having it for, I don't know, if they're saying they're having it for 3 days, then it could be something like adjustment disorder or something. But if they're, again, meeting this criteria, then it's probably MDD. So you have to play with the timeline a little bit, and that's why it's so important. That's why we have all this blank space here, is to play with that timeline. And really knowing the DSM-5 criteria is going to be important here. Okay. So some other things, right? Ask about anxiety as well. Ask about the basically schizophrenia, psychosis is always important. Depressive symptoms important. Anxiety is important. Let's just say we go back to the family and be like, okay, it seems like your mom and dad had depression and anxiety. Have you ever experienced any depression or anxiety in the past? So we're asking about past medical history here. And past medical history, of course, is important because we're understanding, again, that biopsychosocial, the timeline of their mental illness and state, but also ask about other things. Thyroid disorder, right? If they're having hypothyroidism, that can cause a lot of depression and anxiety. So never be afraid to rule that out, but also something to keep in your back of your head as well. So for him, let's just say he's like, yes, I've experienced depression and let's say depression throughout my 20s and 30s. Okay. Any psychiatric meds that we were on? Okay. Yes, I was on Zoloft. I don't know. Let's just say, I can't remember the dosing right now. Let's just say 100 milligrams. Zoloft, does that even go that high? I think it goes up to, yeah, I was right. Yes, okay. Let's just say it's Zoloft 100 milligrams, taken for 1 year, taper off, right? How long were they taking the medication? Like I said, it takes about 4 to 6 weeks for the medication to work. So if the patient only took it for 2 weeks, that's not a good trial of the medication, right? Let's just say they took it for not 1 year. Let's say they took it for, say they took it for 1 year. Okay, so they know what depression feels like. They're saying like, yeah, they're a little depressed. Okay, you know, was there any time when you were feeling depressed or outside of depression that you felt like harming yourself or hurting yourself in any way? Let's just say they said in the past, no. Okay, any past psychiatric hospitalizations? Yes, let's just say they have 3 psychiatric hospitalizations in 2012, 2010, and 2020 for suicidal attempts via hanging. Okay. So now we're getting a clearer picture on how severe this patient's depression is. Now would probably be a good time to ask, okay, are you having any thoughts of hurting yourself now? Hopefully by this time, at some level, the patient's built some rapport with you and is honest with you about what they're feeling. Because before, if you remember, this patient was like, I need to go home. Hopefully this is giving a clearer picture of how they're feeling right now. So let's just say he says, yes, to make it easy on yourselves, I've been having thoughts of hurting myself. Okay, do you have a plan and an intent? So that's kind of the requirements that we need to see. Do they have a plan? Yes, actually, before I got here, I planned to drink 2 handles of Hennessy and 2 handles of Hennessy and shoot myself with a gun. Okay, so now we have access to firearms, which is huge, and we have a plan, and then now we also had intent. Okay, so now they're really meeting criteria and giving a better idea for that this patient needs to be hospitalized, right? If they had passive suicidal ideations, hospitalization might look a little different. Now with the firearms, okay, are your firearms locked away? Questions to ask, right? Are your firearms locked away? Are they loaded? Are they in a safe? Let's just say he says they're loaded. Okay, bad. They're in a safe. They're not in a safe. You know, they're in under my bed. Okay, so now we have real major concerns on sending this patient home. And if you remember, there's no one home with the patient as well. So it's really giving some concerns. Okay. Here, now we have a better idea on that this patient most likely needs to be on a hold. It's also very important to ask about other things as well. Trauma history. You know, is the patient going through any physical, physical, mental, or emotional abuse. This can give insight to PTSD. This can give insight to, any reasons for panic disorder, any reasons for depression as well, self-injurious behaviors as well. So make sure to ask these questions. You don't need to go into detail on what the sexual abuse was, what the physical or mental abuse was either, what the emotional abuse was. I like to preface this with asking questions about any head trauma, because some of the medications obviously decreases seizure threshold, like bupropion, Wellbutrin. So I like to ease that in first. I'm going to ask you some sensitive questions about trauma history. For example, any head trauma or comas or concussions? No, none of the above. Okay, what about any physical, mental, or sexual trauma? Let's just say he has physical trauma from dad and, emotional abuse from dad too. Okay, we're not going to get too into it. It doesn't help anything. It just gives, a clearer picture on what this patient's going through as well, might give some understanding of the patient's history. Legal history. This is really important for, patients who we might be concerned for bipolar disorder, right? A lot of times that they might have, illegal activity and things like that. It also gives idea for antisocial personality disorder as well. So legal history asking, just some questions I want to ask. Have you gotten into any legal trouble by the police ever? No, not at all. Okay. All right. So now we've pretty much asked everything we need to ask, right? With the medications, it's also important to ask how long the medications have worked. Did they work at the time? Why were they stopped? Things like that too. I think I covered pretty much everything. So now we have a bunch of information and it's overwhelming, right? We've asked these questions. I think as a third-year medical student or at the beginning of a fourth-year medical student, just asking the questions and getting all of it is the most important part. Right, so now we have a lot of information. As a third and fourth-year medical student, this might be overwhelming, but it's developed a clinical picture. You've asked all the questions, you have writing and checked off everything in the checkbox. That's the most important thing. Now we need to ask, and we understand why we asked the questions we did and how it helped slowly form what we need to do with the patient and our diagnosis. So hopefully that was helpful. I know it feels kind of random and we're kind of going back and forth between things, but I would encourage you to start practicing that early because that'll make you a better clinician, especially in this field later. In general, when in doubt, kind of work on building a therapeutic alliance by asking the questions on the right first, asking the medical history, the substance history, the trauma, the family history, and in a way that the patient is bringing them up to themselves and they're leading the conversation, but you're guiding it with the questions that you want to ask. With that information, go into, and after you build some rapport and understand what the patient's going through, build that rapport here with, and build the diagnosis here with these things, and make sure to, with the DSM-5, and make sure to rule out other diagnoses that you might be suspecting as well. Another thing that I learned from a great preceptor of mine is ask 3 wishes, and this has really helped me when I'm confused on what to do. And if I feel like I'm not getting a lot of information, this patient that I presented today is giving it information relatively well. If the patient is more guarded, asking what are your biggest 3 wishes that you would hope to get out of life and this meeting. Let's just say they say, I wish I wasn't depressed anymore. I wish I took care of myself anymore, and I wish I didn't stress so much. That can kind of give you a leeway to say, this is what I can offer as a clinician, and also tackle these things. I can tackle all these things with the medication that I'm going to prescribe, and with the CBT or therapy, and with the inpatient setting and what they allow here. So with that all in mind, it feels like a lot of information, so let's summarize it, right? So this is something that now we can do. So 57-year-old Caucasian male comes in for suicidal ideations and vertical lacerations on forearm, brought in by Orbiba. Ambulance from home. Patient came in voluntarily. So all these things are important, right? We'll get into more of that later, but let's just kind of form what we've gathered so far. Patient denies any past medical history, but past psychiatric history of depression. Previously on Zoloft 100 milligrams, tapered off after 1 year after depressive symptoms went away. Past hospitalizations include 3 psychiatric hospitalizations in 2010, 2012, 2020 for suicidal intent via hanging. Patient currently meets or states that they have criteria for MDD for 1 month, stating sleep disturbances, decreased interest, guilt, decreased energy, concentration, and suicide ideations that happen 4 times a week as well. Family history includes mom and dad with depression, anxiety relatively, both who took in Lexapro with with good efficacy. Patient today is endorsing stress due to work and recent divorce and requiring him to take care of 3 kids, and is currently endorsing thoughts of hurting himself with plan and intent via drinking alcohol and gun, which he has under his bed, unlocked, loaded as well. Collateral not attained at this time, but we'll get as well. Utox upon coming into the ER was negative, or Utox was positive, blood alcohol level was XYZ at the time. Okay. With that information, this is more kind of like a slam dunk case of we need to admit this patient, right? We have this history of suicidal attempts. We have this history of depression. We have this history of how this patient's appearing today. We'll talk about them MSC at another time. But this all kind of leads to a concern that this patient's not safe to go home. He needs to be at an inpatient facility milieu where he can get some therapy, start on some medications, and also kind of get his mind cleared up on what we need to do, with social workers and things like that in the future. How inpatient works and how it helps patients who might be suicidal is, a question of its own, but that's for a later time. I hope you guys were following along with this and kind of adding your own information. And I want to take a step back and pretend like I was a little bit earlier, how it would sound if we did this like a normal intake in a different setting. So if I went down and said, okay, are you having any depression lately? And he said no. And I said, well, are you sleeping okay? No. Do you have any decreased interest in things that you normally like? Yes. Are you feel guilty about anything? Yes. Decreased energy and concentration? Yes. Okay, do you have any history of trauma? Any sexual, emotional, physical abuse? Okay, well, are you taking any substances? Okay, well, are you stressed about anything, work or family-wise? Think about how that interview might have been different and yielded a different result than the one we did pretty well today, right? The patient would not be maybe forthcoming with a lot of this stuff, and you might have a different picture of what to do with this patient after doing your whole intake. So I hope that was helpful. I know this ran a little long. I promise you the rest of these are going to be hopefully shorter, and we're going to continue with the same example. And I hope that this was helpful. Again, it's all about working slowly, building the rapport, asking the right questions, understanding why we're asking the questions we're asking, which I hope you got today, and how that's leading to our diagnosis, and asking it in a conversational way, which I hope you guys got an understanding of through this as well. There's so much more I want to discuss, but I think for a 3rd and 4th year medical student, I think this is a good place to end.